and we're moving on with our presentations of the work in the Duke Health System. Next up is Dr. Jedrek Wosik, Cardiology and Informatics Fellow at the Duke School of Medicine, and he will talk to us about acute events and telehealth in our health system during the COVID-19 pandemic.
Thank you very much. It's really an honor to be talking with you all and sort of learning and listening to all of these amazing speakers. I just wanted to share with you some of our ongoing work that we're doing to better understand our hospitalization inpatient encounters as well as our outpatient encounters, how we've used telehealth to address the COVID-19 pandemic, and what we've learned from that and where we have to go. I'm just part of a larger team that's looking into this, and so much more to come from this entire team. But I'd like to just share with you kind of the way that we think about it. First are these milestones, and then really these milestones, some may know very well. For those with childcare duties, when Governor Cooper closed the schools on March 14th, that was a milestone that we've used for some of our analysis. The stay-at-home order on March 30th was another important point that we thought across the state would impact some of our volumes. And then now as we go along with phase 1, some gradual reopening of the businesses and economy, and then phase 2, where we are now at the safer at home recommendation or lifting of the stay-at-home order. Just going into what we've seen and what we're seeing here, this is a plot of our 30-day average daily hospitalization for myocardial infarction and stroke. And so here what you're seeing is in red, the 2020 line, and then in yellow kind of gold, 2019 line of our myocardial infarction and stroke admissions and hospitalizations. And we see some of those same milestones where the schools closed, there's a stay-at-home order, and we certainly see that the curves split, and they split pretty dramatically around those milestones, where less patients are being hospitalized for myocardial infarction and stroke. I'll just note that the y-axis on the left there doesn't go to 0. And when we look at things like, in particular, myocardial infarction, we see that, again, that curve is split, where the hospitalization rates have gone, the incidence has gone down. And then also the same thing can be said for decreased incidence of stroke hospitalization during this COVID-19 pandemic. And we're not only seeing that decreased myocardial infarction and stroke hospitalization rates, but we're also seeing increased mortalities during some of these periods. And so just for all admissions, we've seen an increased mortality during a period of this time, which again supports that COVID-19 is a serious and very serious threat that we are addressing. But if we look at, again, some just specifics of those myocardial infarction and stroke admissions, we see that there are some differences. So when we compare the hospitalizations in terms of race, we do see some racial differences. We see some mortality differences that we mentioned in the plots before. And then we see, interestingly, a length of stay difference. And so this is perhaps an effort to care for patients both on the inpatient side as well as the outpatient side. And so as we think about the outpatient and telemedicine in particular, we've proposed before sort of these 3 phases of the COVID-19 pandemic in terms of telehealth, where there's going to be a shutdown or a significant reduction of outpatient access, where many practices will convert to video telephone in interventions, where there will be some need for more volume and increased volume of patients that need to be taken care of by clinicians and conserve PPEs, where telehealth can play a role. And then this growing care debt, where people are potentially deferring care, which is what we see here in terms of the incidence of myocardial infarction and stroke being decreased, where there's a growing care debt that will need to be taken care of in these perhaps hybrid models, including telehealth. And so what has Duke done in terms of its telehealth? And this is, again, a fantastic team effort across the entire enterprise. But at the peak, when we were offering telehealth, we were seeing 3,000 telehealth visits, so telephone visits a day. And that was representing more than 50%, sometimes 80% of the volume. We were still seeing a few inpatients, in-person clinics. But again, even now in June, when our clinics have reopened with strict safety precautions, we're still seeing 18% of our volume coming from telehealth. And we're seeing not only telephone and video, we're seeing patient portal messages. So the digital kind of email form of interactions have gone up. Here we're looking just at primary care and cardiology, where those volumes have gone up pretty significantly in terms of the way that patients are trying to engage with their health system. But if we look at some of the details and the specifics, this is where I think we want to make sure that we're very, very diligent in this, where we're looking at the differences between the telehealth encounters and the in-person encounters. And here we see, just for the cardiology practices, there are racial differences in terms of who is using telehealth, whether that's video or telephone, and what's being offered. We know that some of the telehealth visits don't include vitals and physical exams, or a complete physical exam or a full physical exam. But we're also wanting to understand, are we providing an equitable access as well as value? So are our clinicians able to order new medicines? Are they able to order labs? Are they ordering procedures during those telehealth visits to make sure that they're providing quality care? So the pandemic has certainly impacted the health of our community and our patients, and we've responded as a health system, but we're seeing differences. We're seeing differences in terms of MI and stroke hospitalization rates. We're seeing mortality differences, and we're seeing a decreased length of stay. We know that our outpatient practice has been transformed, and we will see where the future takes us, but we do see differences in terms of patient characteristics and some differences in utilization of certain procedures or orders around that telehealth visit. So it comes back to that we need to urgently answer these questions of how do we make sure patients are coming into the hospital, that they feel safe, is it safe to come back, and what's the role of a sustainable and equitable and value-driven approach for telehealth and the hybrid model. And so I leave us with this slide, is that this slide was pre-COVID, I'd say, and now the updated slide will be for us to decide how it looks, how our new health system and healthcare delivery system looks. And we look forward to presenting more work as it's completed. So thank you for your time.
Thank you very much, Jedrek. Great compilation of data, and hopefully more will be collected. One question, which is probably you can't answer with data yet, but maybe your anecdotal experience and conversations. Do you think that this shift to telehealth phenomenon is going to be a lasting one based on what you're seeing, or once the pandemic finally subsides, which we hope will happen and happen soon, that will get back to normal office visits? So, and I think the question has two dimensions. One is, what will the patients like versus what will the providers like?
Yeah, absolutely. And we're seeing this from the payers. The payers are extending their coverage for out to December 31st, 2020. We've known that sort of CMA and CMS have mentioned the genie is out of the bottle. We know that some patients really like the access and the availability of clinicians and healthcare. But I think that the question will be is, for whom does it work? Does it work for those without the proper technology, the digital literacy, language gaps? And so I think this hybrid model will be the key, and I think it will be a true hybrid model. But we need to define and analyze and share and publicize what we find.
Very good. One other important question. Do you have measures of MI death out of hospital? It would seem that we would expect additional deaths due to MI over the past several months due to a lower number of in-clinic procedures, such as hence higher level of psychological stress during the period.
Yes, so actually there's been a decrease in out-of-hospital MI as well. So it's almost as if that many are not seeking care in many ways, and then not being appropriately sort of diagnosed or understood why they are passing, sort of the excess death phenomenon. So I think that's a fantastic point of the value in terms of which procedures are we needing to do, what are the frequencies of those procedures. I'll just share with you our data in terms of what we've looked at the outpatient cardiology clinic. We're still seeing stress tests being ordered from telehealth visits. So it seems that telehealth visits, you are still able to appropriately risk stratify certain patients with things like stress testing.
Thank you very much.